Hello, good evening. Thank you for standing here still. And thank you for the organizing committee for giving me the opportunity to be here today to discuss the highlights of last ASCO. Here are my disclosures. And here are the topics I'm going to cover, which will not include relevant trials that were presented at last ASCO, but that are also being presented in this meeting. So starting with esophagogastric cancer and the MET pathway, MET is overexpressed in 40 to 60% of esophagogastric cancer and can be amplified in 5 to 10% of them. And this is generally associated with a poor prognosis. We've got now several drugs targeting this pathway that have been tested in esophagogastric cancers. Relotumumab, a monoclonal antibody against the ligand AGF, Onarduzumab, a monoclonal antibody against the MET receptor, and also AMG 337, which is a small molecule TKI against MET. So we had some early results that were encouraging with some of these agents, including results from the phase 1 study with AMG 337, which had reported an overall response rate of 62% in MET-amplified patients. And we had also a positive randomized phase 2 study that was published last year with relotumumab in combination with ECX that showed that the addition of this drug improved PFS, particularly in MET-positive patients. But we had also more recent results from phase 2 randomized studies, both with relotumumab and onarduzumab in combination with FOLFOX that reported some negative results too. So in this context, the ReloMET-1 study was presented, which included 600 patients with advanced, untreated gastric or gastroesophageal junction tumors that were MET positive and HER2 negative and were randomly allocated to receive ECX plus relotumumab or ECX plus placebo. The main endpoint of the trial, which was overall survival, was absolutely negative. Indeed, relotumumab treated patients did somewhat worse. And when they tried to analyze whether the magnitude of MET expression could influence this outcome, they found that a higher MET expression was neither associated with a worse prognosis nor with improved outcome with relotumumab. More encouraging, however, were results with immune therapy. PD-L1 and L2 are often overexpressed, at least in certain subtypes of esophagogastric cancer. And this ligand overexpression facilitates tumor escape from immune surveillance and is associated with a poor prognosis. In addition, alcohol and tobacco, which are some risk factors for esophageal cancer, induce mutations, and this has the potential for neoantigen production, which we have learned by now that it's a good thing to have in the context of immune therapy. Some new data were presented regarding the activity of Pembrolizumab in this setting, which is a fully human IgG4 anti-PD-1 monoclonal antibody with a broad spectrum of anti-tumor activity that is currently being tested in more than 30 tumor types, including AGC. So results from the esophageal cohort of the KEYNOTE-028 phase 1b multicohort study of Pembrolizumab for PD-L1 positive advanced solid tumors were presented. 45% of screened patients were PD-L1 positive, which was a requirement for study entry, and finally 23 patients were accurate. Here you can see that over 50% of these patients, generally heavily pretreated, achieved some degree of tumor shrinkage for an overall objective response rate of 30%. And these included responses documented in all histologies, both squamous cell carcinoma and adenocarcinoma. And these results are very consistent with those reported for gastric cancer in the KEYNOTE-12 study. So results of Pembrolizumab are encouraging. although we should probably try to improve on patient selection, we have some data indicating that certain subsets may be more sensitive to these agents, and we should at least try to test this hypothesis. There's certainly an ambitious ongoing development of immune therapy in EGC, including Pembrolizumab and other agents, alone or in combination with different chemotherapy regimens, both in pretreated and chemo-naive patients. That will certainly provide us some very relevant data in the near future. Now, how about hepatocellular carcinoma? So more on immune therapy again. Very interesting data. Very interesting were the results of this phase 1/2 study of nivolumab in hepatocellular carcinoma. You know, HCC is typically an inflammation-associated cancer, often related with chronic viral infection, which is associated with upregulation of PD-1, and this upregulation is associated with poor prognosis. We had some preliminary encouraging data with anti-CTLA-4 agents such as tremelimumab in this setting, not only with regards to tumor control but also regarding viral clearance. So the nivolumab study was designed as a dose escalation study in 3 independent cohorts: uninfected HCC, HCV-infected, and HPV-infected. No MTD has been documented to date, but the 3 milligram per kilogram dose level has been selected for cohort expansion in the uninfected and HCV-infected cohorts. And dose escalation is still ongoing in the HPV cohort. Regarding safety, nivolumab was really very well tolerated. You know, liver toxicity was indeed a concern with these agents in this setting, particularly in viral-related HCC. But only 11% of patients had a grade 3 or greater elevation of AST. The objective response overall was 19%. Remember, almost 70% of patients had priorly received sorafenib. And responses were seen in all cohorts across all those levels. And particularly important or noticeable were results in the HCV cohort with 36% response rate. These are small numbers, but still very, very interesting. So I think immune checkpoint inhibition is really a very interesting strategy for this disease, as it enhances effective T-cell immune responses, not only against the tumor, but also against the viral antigens. And nivolumab proved to be safe in this setting, also in viral-related HCC, and it seems to be better tolerated, in fact, than some agents currently used, such as sorafenib. So it's certainly an avenue to continue. How about neuroendocrine tumors? I'm going to comment on 2 relevant studies. The first one, the SWOG SO518, was included 400 patients with G1, G2 nets with poor prognosis, defined sort of in a loose way. It could be either progressive disease or refractory syndrome or G2 or typical histologies or colorectal gastric primaries. But in fact, 85% of recruited patients were G1 tumors, and 1/3 were of mid-gut origin. So it ended up recruiting a better prognosis patient than what it had initially pretended. But anyhow, these patients were randomized to receive octreotide with interferon or with bevacizumab. The rationale for this design was based on some old data, small phase 2 randomized studies that suggested interferon could improve symptom control in this context and could also prolong PFS. And this was meant to be the control arm, which is to a certain extent debatable. And this same group had a more recent data on a randomized run-in study that suggests that bevacizumab could be more effective than interferon in this setting. So this was the rationale for the study design. But the main endpoint, which was PFS by central review, was negative in the sense that both it was similar in both study arms. Although bevacizumab treated patients had a higher response rate, 12% versus 4%. Regarding safety, nothing really unexpected, but it is to note that 26% of patients treated with interferon had grade 3 or higher fatigue, which is indeed an issue in these patients with relatively indolent disease. So in terms of tolerance, I think bevacizumab is better. So the second study I'm going to comment is this CALGB 80701, which is included 150 patients with neuroendocrine tumors of pancreatic origin that were randomized to receive everolimus or everolimus with bevacizumab, both arms in combination with octreotide. PFS was the main endpoint of the study. It was 14 months for the everolimus cohort and 16.7 months for the bevacizumab combination, with a hazard ratio of 0.8 and a p-value of 0.12, which did cross the predefined significance level, which was set up at 0.15. The overall response rate was increased from 12% to 31%, as were the grade 3/4 AEs from 49% to 81%. Basically, at the expense of non-hematological toxicity, great proportion of them were hypertension, but not only. So how do we interpret these findings? What does the SWOG study tell us? It was were bevacizumab interferon and interferon equally effective or equally ineffective in this setting of rather good prognosis nets? Although I think probably the first thing, but we can't really tell from this trial. And adding bevacizumab to mTOR inhibitors, although it increases response rates and seems to modestly prolong PFS, it also increases toxicity. And is this really practice changing? Well, I don't think so. But do these strategies deserve to be further explored? Yes. We still need to learn a lot about what's the adequate disease setting, the adequate patient selection, optimal sequencing, and so on of these treatment strategies. And the last part would cover colorectal cancer, two very interesting studies. First one I'm going to comment is the HERACLES trial, which was conducted in advanced colorectal cancer that had failed prior standard therapy, which had to include an anti-EGFR agent. These patients were KRAS exon 2 wild type and HER2 positive, and were treated with dual HER2 inhibition with a combination of trastuzumab and lapatinib. This design was based on some preclinical evidence that shows that HER2 amplification is a driver of resistance to cetuximab in PDX models, and these tumors were very sensitive to dual HER2 inhibition in this preclinical model as compared to treatment with either agent alone, particularly as compared to trastuzumab alone. And so a great effort has to be acknowledged to HERACLES investigators that had to screen over 800 patients to identify 5% of HER2 positive ones to finally be able to accrue half of them. So 23 patients finally were included in the trial. The objective response rate, however, was very remarkable for this very refractory setting, 35%, with a disease control rate of 80%, which did indeed meet the primary endpoint of this trial. And the final study I'm going to comment is this one, which is probably the most relevant of all presented, PD-1 blockade in tumors with mismatch repair deficiency. You know, average tumors have dozens of mutations, whereas MSI tumors harbor thousands of them. Mutations have the potential to generate novel non-self proteins that can be identified and targeted by our immune system. So the hypothesis was that MSI tumors would be a lot more sensitive to PD-1 blockade than average tumors. So this study included 3 cohorts, 2 colorectal cancer cohorts, both deficient and proficient in mismatch repair, and a non-colorectal cancer cohort which were deficient in mismatch repair. This included some GI tumors, small bowel, biliary, also endometrial and others. And all these patients were treated with pembrolizumab at 10 milligram kilogram every 2 weeks. So very impressive, both MMR deficient cohorts, both colorectal and non-colorectal tumors had over 60% response rate versus 0% in the MMR proficient tumors. And of note, these responses were achieved rapidly, they were profound, and they were durable. And they had indeed a very relevant impact on the PFS of these patients. And a mutation burden was associated with efficacy. So this is really a very important proof of concept study that demonstrated how tumor genetics is the right way to go for patient selection for immune therapy. And mismatch repair deficiency is present in 5% of tumors of different origins: colon, rectum, endometrium, stomach, bile duct, pancreas, etc. And it is an easy thing to test with commercially available tests that most of us, I think, we have in our routine daily clinical practice. So this is just my last slide, just with some take-home messages. Regarding the esophagogastric cancer, I think the MET pathway shall not be further explored unless we find better biomarkers to select patients for it. But we got some encouraging data with anti-PD-1 therapy, although data is still limited. In the context of hepatocellular carcinoma, anti-PD-1 therapy again was very promising and certainly deserves to be further explored. In the field of NETs, anti-VEGF therapy led us with more questions than answers, and we really don't know whether bevacizumab was not as active as we expected to be, or maybe interferon was more active than what we thought. But regarding the combination with mTOR inhibitors, in my view, was a bit disappointing. And in the field of colorectal cancer, the 2 trials I commented, I think they are very important ones. Not only the anti-PD-1 therapy in MSI, which is really very exciting news, but also the HERACLES trial teaches that we really need to start analyzing our tumors from the molecular point of view in a more detailed way to find or to search for actionable targets that even if they are present in a very small proportion of patients, they can benefit a lot from certain therapies. So we have to start treating all patients in the same basket. And that's all. Thank you very much for your attention.